Unlike the implantable cardioverter defibrillator (ICD), which is implanted subcutaneously, wearable defibrillator (WCD) is worn as a vest. Defibrillation patch electrodes and monitoring system are included in the vest, and the defibrillator with battery is kept on the belt externally. WCD automatically detects and treats ventricular tachyarrhythmias without the need for assistance from bystander. Though the original device used monophasic shocks, later ones had a biphasic shock waveform. The biphasic device had a maximum output of 150 joules and could terminate ventricular fibrillation at the first attempt with 70 joules in 12 and 100 joules in 10 of the episodes tested. Still, programming at maximum energy output has been suggested for ambulatory patients to ensure good safety margin. WCD has been called as a life vest till the lifeboat arrives, meaning that it can be considered during the initial window period after acute myocardial infarction when the patient is not eligible for an ICD as per guidelines. One study of real-world utilization of WCD was reported in 2017. Of the total 140 patients, 46% had non-ischemic cardiomyopathy and 32% had ischemic cardiomyopathy. Some of the patients had genetic predisposition for sudden cardiac death, while some had an ICD explanted. Mean daily use of WCD was 17.3 plus minus 7.5 hours. The usage time was lower than the 21.3 hours presented by Dhillon K.A. et al. In another study. Usage time implies an Achilles heel of WCD compliance. The lower the usage time, more likely that an unprotected arrhythmic event can occur. A systematic review and meta-analysis published in 2019 found 28 studies, of which only one was a randomized controlled trial, while 27 were observational studies. There were 32,426 patients in the studies reported. Appropriate WCD therapy occurred in 5 per 100 persons over 3 months. In the West trial, the incidence was 1 per 100 person years over 3 months, compared to 11 per 100 person years over 3 months in the observational studies. Inappropriate WCD therapy occurred at a rate of 2 per 100 persons over 3 months. Mortality while wearing WCD was rare, 0.7 per 100 persons over 3 months. West trial had randomly assigned in a 2:1 ratio patients with acute myocardial infarction and an ejection fraction of 35% or less to receive a WCD with guideline-directed medical therapy or guideline-directed medical therapy alone. Of the total 2,302 patients, 1,524 were allotted to WCD and 778 to control group. Arrhythmic death occurred in 1.6% of the WCD group and 2.4% of the control group. Death from any cause occurred in 3.1% of the WCD group and 4.9% of the control group. It may be noted that of the 48 participants in the WCD group who died, only 12 were wearing the device at the time of death. This could have led to the lack of statistical significance in the arrhythmic death between the WCD group and control group in the West trial on intention to treat analysis, once again highlighting the compliance factor in WCD. Per protocol analysis of West trial showed that there was a significant reduction in total and arrhythmic mortality, again highlighting the compliance factor. Some of the factors which independently predicted WCD compliance were cardiac arrest during index myocardial infarction, higher creatinine, diabetes, prior heart failure, and number of WCD alarms. Among the factors predicting worse compliance were higher body mass index, prior percutaneous coronary intervention, and any WCD shock. 2017 AHA-ACC HRS guideline had given Class 2A recommendation for the use of WCD in secondary prevention when ICD removal is required as with infection, and 2B recommendation for all other scenarios including primary prevention. The Class 2B indications included patients waiting for a cardiac transplant, post-myocardial infarction patients with left ventricular ejection fraction of 35% or less within 40 days of infarction, newly diagnosed non-ischemic cardiomyopathy, revascularization within past 90 days, myocarditis or secondary cardiomyopathy, and systemic infection. Basically, these patients were at increased risk of sudden cardiac death but ineligible for an ICD. A systematic review published in 2021 evaluated the evidence on WCD in patients undergoing ICD explant bar lead extraction. They also compared the use and cost of WCD with standard therapy in hospital stay. Their cost minimization analysis showed a cost reduction of 1,782 euros per patient using WCD. The calculation was based on a reduction of hospital stay from 21 days to 15 days with the use of WCD. They noted that after ICD explantations, patient can be safely and effectively protected from sudden cardiac death after hospital discharge through WCD utilization. First set of journal references. Second set of journal references. Third set of journal references. Fourth set of journal references. Fifth set of journal references.